Our next up, I'm going to welcome Morgan Honey, our Executive VP and COO, to the stage. Our next session is going to be an update from Contexture on what we've got going on in Colorado, with some interspersed just updates about what's happening in Arizona as well. One of the things we have done over the years when we've had different community events is we find that there's a lot of interest from attendees and from the audience in just hearing about what we are doing within our own organization to support the community. And we used to put this session towards the end of the day, and then we recognized that it was a little better to put it early on so that way if you've got questions for our team, for us, and it might influence, how you look at some of the other sessions throughout the day, we thought it was a good opportunity to share what we have been up to. So Morgan and I are going to share this presentation and do a little bit of back and forth. The plan for this session is to talk with you a little bit about Contexture basics. Hopefully folks are getting used to saying our new name as we completed our merger between Health Current and CoRio last July. And we've been doing this transition over the last year to transition from our old names to our new names. So we're going to give you a little background on Contexture basics. Morgan is going to go through Contexture service updates, again with a focus on what we are doing here in Colorado and interspersing a few updates of what's happening in Arizona so you have a flavor for what we do across the organization. Then I'll come back up to the podium, share a little information about our next 3-year strategic plan, which I'm pleased to announce has already been finalized and approved by our board, and we're looking ahead to 2023 and beyond of all the things we can continue to do to support the community. And then we'll wrap up with a few insights and updates on where we fit and the impact of national interoperability efforts to our communities in Colorado, because there's a lot of things going on at the national level. We live and breathe this every day, but we recognize, you all have very busy lives and just a few updates so that you know what's going on out there in the broader interoperability ecosystem. So, again, if you don't know, we are now Contexture. Health Current and CoRio came together last year in July of 2021 and formally created Contexture as the regional umbrella organization that includes both Health Current and CoRio. So we are the statewide health information exchange in Arizona. We cover about 85% of the population in Colorado. You all know that we have 2 HIEs in Colorado, so we work always collaboratively and with our partners at Quality Health Network on the Western Slope. Hopefully we have some representation here from QHN today, and we continue to continue that collaboration and advancing efforts that supports the entire state of Colorado. So this is the region we cover today. We came together because we think that there's a lot of opportunities to leverage expertise that we have in both states to further advance our services in both of our states and really to continue to support communities throughout the West. I threw this up for our presentation today because I want to make sure and reiterate that we have a brand new website. If you have not checked out the new contexture.org. We've had this website up for over a year, but we just rolled out the combination of all of the great information that we had on both the Health Current and CoRio websites all into one consolidated site. So this took a lot of effort because our websites were very resource and information heavy. But one of the things that I really love about how we've come together is really how we categorize the services we provide to the community. So this is a snapshot of the homepage. I encourage you to visit when you've got a chance because there's a lot of great information on it. But across the bottom are the 6 different categories of services that as we look to the core HIE services that HIEs across the country have always provided, there's a lot of new and different things that we do that really expand beyond traditional HIE. So HIE obviously is our history and continues to be a large portion of what we do. But we also have significant services in the areas of quality improvement, in data analytics, in social determinants of health, in advanced directives, and in public health. So as we look today to review the services that we provide throughout our communities, we're going to focus in these different areas to give you an insight into what we do in each category. We have 28 million patients across both states in Contexture's systems today. That's really significant breadth and depth of information. Both Health Current and Coreo have been collecting data from participants across our communities for over 10 years. So that's a lot of history. It includes people who may no longer be with us, who have moved to other states, who have moved into our states, who have moved around, and as well as information that we exchange from visitors that come from across the country to Arizona and Colorado. We have over 10,000 users per month that utilize our systems across our region, and we deliver over 23 million alerts per month. So that's just a few snapshot metrics into our network, and I put up here as well another screenshot from our website, because we have a variety of different blogs, news stories, case studies that really shine a light on all of the successful health IT and health information exchange innovations that you all as organizations have implemented over time to advance our objectives in healthcare. So we have over 790 participants in Colorado. We're really nearing in on the 800 number, which is really exciting. We support over 700 interfaces that send clinical data on patients and share that information across our communities. And we have data available, and these are all Colorado metrics on over 11 million individuals. So you can see here how those participants split between different categories. You've got hospitals and health systems, health plans, accountable care organizations, long-term post-acute care, behavioral health, which is an area of increasing focus, as we just heard, and certainly will be for Contexture as well, state and local government, emergency medical services, labs, imaging centers, and pharmacies, and then this catch-all category of, I missed the FQHCs and rural health clinics, and then the catch-all category of community providers, which includes primary care practices, specialists, and other types of healthcare provider organizations that might not fit neatly into those other categories. So again, huge network. We've seen a lot of success and participation over the years and look forward to continuing to grow that in different areas. So with that, I'm going to invite Morgan up to the stage. He's going to share a little bit more about all the services we have in each one of those 6 categories.
Thanks, Melissa. Can you guys hear me okay? I'm not a podium speaker, so I'm going to wander. And I'm freezing, so I've got my Contexture swag on. So as Melissa said, I was thinking about this morning. It was March 16th of 2020 when we were literally all packed like sardines into the conference room at the Coreo offices at the time, and we sent everyone home. That was when the pandemic really hit, and we decided that it was time to lower the risk and send people back to their homes to work. It was really amazing because the work only accelerated starting on March 16th of 2020. Melissa's going to wrap up with talking a little bit about our strategic plan. One of the things that we heard loud and clear from our stakeholders as we were going through that process is we've been so buried for the last 2.5 years that we've lost track of all the things that you guys have done. And so what I thought would be of value today would be to update you on what has been going on at Contexture, what are those things that we have been building, testing, analyzing in the background in order to support A, your pandemic response, but then B, just trying to make the work that you all do easier and better for those patients that you're all serving. you all know, health information exchange services are our core. It's all about connecting systems together so that you can have access to data regardless of where your patients may be seen in the community. Melissa highlighted the network as it is today. If you want to go out, we've developed these new user guides that are available on the Contexture website. I would really encourage you to go out and see the catalog of all of the services that we can provide at this point. It's a really comprehensive resource. The other thing that we announced earlier this year, recognizing that our rural communities have been hit probably harder than anyone else for the last 2.5 years. As somebody who came from a rural healthcare administration background, I have lived firsthand the challenges that healthcare providers in rural communities face on a daily basis. One of our goals at Contexture is to always try to break down the barriers for people to participate in the HIE so that you can have access to the same technology, the same products, the same services as everybody else, the biggest systems, the most wealthy systems in the state, that those communities in the rural areas have access to those as well. So earlier this year, we announced our Free Forever for critical access hospitals and rural health clinics. This was our way of saying, please, we want you to be a part of this network. We want you to have access to these services that are readily available and a way to extend an opportunity for rural clinics and critical access hospitals that otherwise maybe that cost was standing in the way. Free forever. We also heard Dr. Medlock talk about the priority of behavioral health integration and access in Colorado. We have been working at Contexture on behavioral health, and I'm looking at Kelly and giggling a little bit, for 10 years. I mean, this was a priority when we started the HIE 10 years ago, 12 years ago. It continues to be a priority for many stakeholders in the state. If you're familiar with health information exchange and all of the policy that surrounds the work that we do, 42 CFR Part 2, a wildly outdated policy from SAMHSA, is currently being updated. I'm looking at Annie. I think that we're awaiting that update like any day now. But we really are looking at being able to launch our consent methodology to integrate behavioral health information exchange next year in 2023, and then rolling that out more broadly in 2024 to get directly at those priorities that Dr. Medlock was talking about in our keynote speaker. So please look forward to that. One of the reasons that we brought Health Current and Correo together was because we recognize that we're doing really groundbreaking things in both of our states. And one of the goals was to be able to leverage the things that were happening in our local geographies to try and cross-pollinate those lessons learned and those opportunities that we have between Arizona and Colorado. So in addition to the Colorado Health Information Exchange user guide, we've also got resources that you can look into to see what's available in Arizona. And our goal constantly is to try and bring those lessons learned and opportunities between our two states so that when we're doing things in Arizona that are really groundbreaking, like the differential adjusted payment program that provides incentives for providers, massive incentives for providers to participate in HIE and improve their data quality, utilize the data, that we can bring those types of lessons learned and programs into Colorado and vice versa. I'll get into the ECQM work and the practice transformation support that we do here in just a second, but that's another big priority that Arizona is really looking to leverage from the lessons learned in Colorado. We've also gotten into data analytics. And this doesn't mean necessarily that we want to be your data analytics provider, but really starting with the foundation of those 11 million patients that we have information on in Colorado can serve as a huge foundation for understanding how to progress your population health. One of the cornerstones of what HIEs do is identity management. It is critically necessary in order to achieve trust that Dr. Medlock talked about, that we know that when information comes in from a system that is on a singular patient, if you're making clinical decisions about health information that came from University of Colorado and you're treating them at your local ambulatory clinic, we have to be 100% positive that the person that's sitting in front of you, that you're also looking at the right data. This also provides a very powerful foundation for analytics. So during the pandemic, a couple of really interesting things that we did was we used that MPI, the Master Patient Index, a foundation technology within the HIE, to support how agencies in the state can understand more granularly the population that they're serving or may not be serving. So one program that we provided was a collaboration between HCPUF and CDPHE, in particular the WIC program, to understand the eligible but not enrolled population. You might think, like, what the hell does an MPI have to do with WIC and Medicaid? It turns out that the eligibility criteria for children in WIC is almost identical to the eligibility for children in Medicaid. And so by running a cross map of those two eligibility files or member rosters, we were able to identify those kids that are in WIC but not in Medicaid, and vice versa. In about 6 weeks, we turned around a 17,000 member list to WIC for them to provide outreach to get those kids enrolled. That's a tremendous amount of federal funding that was being left on the table simply because we didn't know who these individuals were. We also use this, again, in support of CDPHE and the Colorado Immunization Information System, or SIS, to help enrich the demographics that were missing inside the immunization registry. I'll use myself as an example. In April of 2021, me and my wife drove up to Clear Creek County, don't tell anybody. We got our vaccine on the side of a road next to a CDOT facility. We handed our paper out the window, got stuck and drove away. There's no telling what happened or how complete the demographic profile of me and my wife was when we handed in that paper. What we did is we went through a similar process as we did with Medicaid and WIC, took the immunization system data at a demographics level and enriched it so that we could understand and we could help CDPHE say, we really, we're giving you this information. We recognize that we've got a challenge with underserved communities in rural communities. Are we really reaching all of those race and ethnic groups that we should be, or do we see variability in the way that our immunization rates are happening across demographics? That was something that was powered by the HAE and in partnership with CDPHE. We're also always looking at ways that we can use those connections to the HIE for different use cases. I will tell you again, going back to my background, when I was running my FQHE in eastern Colorado, resources were incredibly tight, and my EMR vendor was not the highest performing. And so anytime that I could make one connection, reduce those costs that I was paying my EHR, and have multiple opportunities to leverage that connection, I was always interested in that. One of the things that we're doing in Arizona, which I think is fantastic, is, and gets directly back to some of the comments that Dr. Medlock made, is how do we use those connections to start to understand system capacity? And so we have partnered with Access, which is the Arizona Medicaid system, to start using those HL7 interfaces that power the HIE to understand what the capacity of the crisis system is for Arizona. The goal would be that if you've got a patient that comes in, needs a bed in an acute facility, sometimes if you're in a rural community, that facility might be 2.5, 3 hours away. By being able to provide insights into the capacity of these crisis beds, we can more effectively know where we're sending patients to places that actually have the resources and the capacity to take them, rather than transporting them 2.5 hours to find out once you arrive, the system is full, and we've got to redirect those. This is a partnership between Access, Solari, which is the 211 program in Arizona, and Contexture, again, utilizing those same HL7 interfaces and the core technology that we have as the HIE. We've also been really deeply involved with COVID response. In 2020, I believe, I'm looking at Deanna, we built our first ever interface, outbound interface for CDPHE, so that we could provide access to healthcare providers for those COVID lab tests that were being provided by the state lab. Even today, the largest tester in Colorado for COVID continues to be CDPHE and that state lab. And so unlocking that data and providing that data through the HIE was an incredibly huge value to the community. We also were able to take that data, ingest, and provide dashboards back to, again, the Arizona Medicaid agency to better understand what is the impact of COVID on the Medicaid population. So you can see a couple of screenshots here from the dashboards that we've built for Access, looking specifically at the immunization rates for access populations, and generally the immunization dashboard, so that we can see, are we seeing variation in the immunization rates across geography, across race, across ethnicity, across payer, et cetera. If any of this is of interest to you, it's all out there on our website. You can go and look at those user guides and find out much more, or you can just grab me anytime you want. One of the things that I'm incredibly proud of at Contexture is our quality improvement program. We also recognize that technology is not always as it's sold. It's not an out-of-the-box solution to many of the problems that you all are facing on a day-to-day basis. And so having resources that can come in, help you, sit down next to you, develop those workflows, develop those clinical pathways so that you really are unlocking the potential of that technology is critically important. So we have a fantastic team of clinical practice transformation experts within Contexture that actually go out to clinics, sit down with providers, support staff, work through their workflows, their patient flows to make sure that they're entering data correctly, that they're entering data in the right place, that when we're pulling data out of the system that it's present so that it can be used for these other use cases as much as possible. Lauren Gerard is going to moderate a panel later today, and so you'll hear more about how real practices and groups are using these services. But we have participated in a number of different programs, such as the Facilitating Alcohol Screening and Treatment Program, It Matters, CDPHE Diabetes and Cardiovascular Disease Program, et cetera. These folks are out in the field on a day-to-day basis helping people navigate how to do these quality improvement activities. We also use the HIE to support quality reporting. So again, one connection, many opportunities. When I was, again, running my FQHC in Eastern Colorado, I had to do a multitude of different reports to the federal government, to the state Medicaid agency, to my different payers that I was participating in at an ACO level. And so what we have been targeting and trying to do and have been doing very effectively with this program is using, again, those HIE connections, ingesting that data from that clinical information, partnered with the practice transformation services in order to make sure that when the data is coming out the backside of the system, that it can be used for quality reporting, specifically with the Medicaid APM program, also CMS and MIPS, to support those reporting requirements. You all know this is a huge burden as you're moving from a fee-for-service to a quality-based model or APM models, and so really excited about this area of opportunity. Some of the improvements that we've seen, you can see here over time as that data improves, gets enriched with HIE data, really provides a huge benefit to providers to be able to leverage that HIE connectivity and have access to the longitudinal information that's available through the HIE, but also to use those connections to support their quality and reporting processes. Again, I will use an example from my background. One of the most common metrics out there, at least in ambulatory care or primary care, is mammography rates. In Eastern Colorado, we didn't have a lot of providers that provided mammography, and so I was constantly sending patients into Colorado Springs or the Denver metro area to get those tests done, and trying to get that information back so that I could use it for my clinical reasons, but also for my quality reporting was incredibly complicated. By using the HIE and leveraging these ECQM services, we're able to consolidate all of that information and really help providers alleviate the burden of gathering that information manually. I remember we used to pay a guy that ran up and down I-70 every day, carrying CDs of radiology reports from Flagler all the way to the Denver metro area. Every day we paid that little guy to drive his car back and forth. I can't imagine how many miles he probably racked up. We've also been I mentioned we've also been very closely partnered with HCPUF on the ECQM and the APM program, again, leveraging that HIE foundation to support the reporting process, but also to gain those incentives from Medicaid that can make a big difference when you're, many times operating on a shoestring budget. As everybody knows, and again, I'm just going to keep referring to Dr. Medlock's opening comments this morning, SDOH is a huge buzzword in healthcare across the spectrum. And so you all know that in Colorado there are a ton of activities going on around how do we tackle this as a state, from a community level all the way up to a state level. Over the last 2.5, 3.5 years, Contexture has tried to tackle this from a number of different angles. I don't know in the back, I couldn't see the slide, so I'll just kind of rattle them off to you. What we've done is we've built 3 pillars to our SDOH approach. First, the community resource model, which is really leveraging those 211 and community resource inventory programs that exist around the state. There are a number of them, to create that central source of truth for when you're looking for that resource within the community, when you need to refer someone to housing or you need to refer someone to food security services, that you know that there's one place that we can go to find what's available in my community. SDOH notifications and HTP support. So HTP stands for the Hospital Transformation Program. Again, another program that's going to have significant reporting burden for hospitals in particular, but creating those connections between what's happening inside the healthcare system with those RAEs, those regional accountable entities, to make sure that A, the hospitals can meet their reporting requirements, but B, and ultimately, that the patients who really need those services in the community can get them regardless of what door they're coming through in the system. And then lastly, the direct referral model. This is where we are working through a program that we call CRISPR. This is integrated in the EMR so that you can say, I've got Sally sitting in front of me. She has just been through her screening process, identifies as housing insecure. I can actually, within my EMR, look and say what resources are available for Sally, and within my workflow, make those referrals. That's an incredibly complicated solution. Deanna's scowling at me over there, but it is something that I believe is of great value to providers, particularly when we've got hospital systems that have invested tremendous amount of resources in their EMR systems. We want to keep providers in their workflow. We want to make sure that we're being cognizant of the limited time that providers have with their patients, and making sure that ultimately the patients get what they need from their communities. And then lastly, just the SDOH notifications. This is, again, leveraging the core HIE functionality, the 25 million notifications that Contexture is sending out every month, to be able to enrich. Not only can we now tell you that, hey, Sally is over here in this particular ER, or she has been admitted to this particular facility, but we can also enrich that information to notify the right folks of, we also see that Sally has a risk of homelessness or food insecurity, or any of those SDOH measures. Again, our goal is always to find better and more ways to leverage the HIE technology and foundation. We're incredibly lucky in Colorado and Arizona to be where we are in our continuum of implementing these solutions. And so we strongly believe that leveraging the HIE will only continue to expedite the impact that we see with our efforts on SDOH. I'd be remiss if I didn't say that in Arizona we've done a tremendous amount of work and are well down the path of implementing a statewide solution for a single platform as it relates to coordinating SDOH information. So in Arizona, we have implemented what's called the Community Cares program, and this really is it's sponsored by the state Medicaid agency. It provides free licenses for a unified platform across the entire state so that folks both in the healthcare system, social services, community benefit organizations can operate from a single platform and have ubiquitous connectivity and interoperability regardless of where they may be serving patients. Again, this is a partnership between the state Medicaid agency in Arizona, Unite Us, which Joe is in the back, Solari, the 211 provider in Arizona, and we're in the first throes of implementing the first communities with a very aggressive timeline of like 18 months working through a county by county implementation plan. I'm almost done talking at you. In Arizona, I would be remiss to say, we have tried kind of fits and starts with an advanced directives registry in Colorado. In Arizona, we have got a fantastic model of what we're doing with advanced directives. As you all know, there is a direct correlation between end-of-life care and health care, and making sure that we are meeting our patients' expectations about how they want that care to happen, what they expect to be done at the end of their lives. And so in Arizona, we manage and host the statewide Arizona Advanced Directive Registry. This is a program where patients can actually upload their advanced directives and their wishes. And it is then not only available to healthcare providers who are interested in that information, but is also portable for patients to be able to keep on them at all times. So it's an app. They can scan the QR code and keep it right there with them at all times. It's a fantastic program and something that I personally am incredibly excited about, because I've seen kind of the fits and starts that we've gone through in Colorado on that front. If you're interested, and ironically, this is an open platform, so if you've got those documents in Colorado, you can actually go out and create an account in the Arizona registry. It's one of the few states in the nation that actually offers something like this. But if you're interested, you can go to azhdr.org and actually look at the platform. You could actually upload your documents, scan that mobile app, and keep your documents with you if you actually wanted to. And then lastly, I'd be remiss if I didn't make a call out to the enormity of the public health work that we've done over the last 2.5 years. So as many of you may or may not know, one of the big incentives for participating in health information exchange through the Meaningful Use program was building those connections to public health for things like electronic lab reporting, immunization systems submissions, cancer registry, syndromic surveillance, and then finally this new program that I'm not so familiar with, but the Unicorn e-referral program that is coming out of CDPHE, really to unify all of these registries so that we can see a population level of what is happening with the public health of our entire community in Colorado. And then lastly, just to build a little bit on the crisis capacity registry, we use the relatively same technology and solution to understand what the bed capacity of hospitals were in Arizona during the pandemic. So this is something that, if you're not familiar with it, hospital systems have to, on a daily basis, go in and update manually many times the capacity of their system in order for the state public health department to understand where are we at. Are we surging? Are we not? Where's our capacity falling? We use those same HL7 interfaces and some manual processes to provide access the Arizona real-time ADT power surge line. And this was a dashboard that Access was using during the pandemic to understand what the capacity of the healthcare system was in Arizona. And then lastly, we also were the recipients of a national COVID-19 dashboard program from the Office of the National Coordinator. Through this program, and we're going to hear some of my colleagues from around the country, we're able to aggregate COVID data that was coming into HIEs from 22 different health information exchanges across the country. Ultimately, these are two screenshots of what we were able to put together, both from a testing perspective as well as an immunization perspective. And you can see down here, I know it's hard to see in the back, but the map shows you where we were able to gather information. This was a little bit earlier in the program. We actually filled out that map quite a bit, but again, Colorado and Arizona leading the charge nationally with demonstrating the value of health information exchange and that foundational technology when we're talking about things like public health response. Is this mine or is this yours? And then lastly, we also recognize that there's a huge value in being able to leverage the data that we have within the HIE to support research. Research is how new treatments get developed, how new drugs get developed, how patients can get connected to clinical trials, how we can use this information to advance science in order to advance health. So one of the things that we're really excited about is we were involved in an HIE research collaborative in Arizona with the NARBA Institute. I couldn't tell you what NARBA stands for, but I do enjoy saying it. to understand how can we leverage the HIE data to support those research activities of teaching universities, of different research institutions that are looking at new and innovative ways to improve health. Me and Melissa and all of our team continue to believe that this is a huge area of opportunity, a way that we can support advancing health, advancing research, advancing innovation, using that same foundational technology that we've been building for the last 10 years. So this is incredibly exciting. I would anticipate seeing more of updates of what we're doing in this space over the coming years. Now I'm done, and I'm going to hand it back to Melissa.
All right, thank you, Morgan. I love seeing the really the impact across both of our states, because every slide that might have had something to do focused on Colorado is something we're exploring in Arizona, and many of the slides that had things that we're doing in Arizona is because of expertise and background and really functionality that we were able to bring to bear through our merger and our partnership. So in every instance, I can't think of any instance that's solely one state or the other. There's just a lot of opportunities for collaboration. And NARBA stands for the Northern Arizona Regional Behavioral Health Association, but at C in Colorado, I would not know what CORD stands for, which is the Colorado Research Initiative, that there's even been focused effort in the using HIE data for research area here. So we'll play a game of acronym soup at the end of all the sessions today. Two last topics. If you've got questions, hopefully we'll have a few minutes left. And if we run out of time, Morgan and I are going to be around all day. Our team members that have tons of expertise in this area and understand the nitty-gritty details are also here. So we will make sure to answer all of the questions. I am really excited that we stand here in the end of October and we've already got our 3-year strategic plan completed. That's in large part thanks to our Chief Strategy Officer, Kelly Joines, who really understood the timeline and the intensity and the need to get this process started early. So we brought together our two approaches that we had historically and created this new approach for our strategic planning. So we will be doing strategic planning going forward in 3-year cycles, and then we will look at each year independently and determine what we need to focus on in that next year to support all of the communities that we serve. So I'm sure we can't see all the details, nor do we have time to go through the details, but the essence of this slide is that it's really, really important that when we do strategic planning, we get the input of what the community wants and needs, because that's our purpose. Our purpose as an organization is to serve the health information technology and exchange needs of the communities where we operate. And so you can see here, we interviewed 185 Arizona and Colorado participants, board members, vendors, and other HIE resources. There were over 50 organizations engaged in this effort, and we also spoke to 178 Contexture team members, and we used some strategic planning activities that we had completed in Arizona to be an input to the strategic plan, particularly in the areas where we focus on Medicaid and public health. Here are the high-level themes. That's a lot of interviews, a lot of information to digest. But the high-level themes that we heard that the community is interested in Contexture continuing to do is keep building out our network. Bring new and different, more participants, different participant types, more and different types of data, continue to work on improving data quality. We have a lot of initiatives in this area, but there's always more we can do, and build out our network geographically. There's a lot of interest in requiring bidirectional exchange. So once you identify and acknowledge all the information you can get, if we all are willing to work together and share that information through an HIE, you want everyone to play equally. You want all of your colleagues to be sending data if you're sending your data, so that everybody's information is available and you have as comprehensive a record as possible. As Morgan mentioned, we're going to have a panel of some of our HIE colleagues from across the country, some of which have some really unique approaches in this area, and we will be looking at different ways that we can require bidirectional exchange. We need to provide a clear value proposition. We often talk to our participants, and we talk about all the services Morgan just mentioned. And number one, Folks don't know that all the different services we provide, and we need to make sure we're doing a successful job of translating how a service brings value to our participants, how there's return on investment, and we've got some exciting initiatives planned for next year that's going to focus in this area. Everybody wants to stay in their workflow. That's probably not a surprise. So we need to continue to develop services that allow not 15 clicks, but just a couple to get to the information you need. And then the idea of information exchange, health information exchange, is really focused on the exchange of clinical patient information. But that same concept applies to lots of different areas. So let's not stop talking about health information exchange and talk about information exchange generally and how we can continue to grow and expand into new areas like analytics, SDOH, public health, and even patient access came up in the discussion. So these are 3 buckets: grow, respond, and lead. These are the 3 areas that we will be focusing on over the next 3 years. Grow is really that focus on expanding the information exchange network. That can mean all the things that were reflected in those themes. It specifically does not say health information exchange. It says information exchange because that concept can apply to things like SDOH, like advanced directives, like public health, etc. Respond is building a data platform that supports current and future integrated data and data access needs. We do operate different technology platforms in both Arizona and Colorado, and we will have a focused effort to get to an integrated technology platform and infrastructure that can both bring the data across both states together in the coming years, as well as make sure we're well poised and we have the right foundation in place to continue expanding. And then lead is ensuring that we have all the necessary training and security and technology in place to have the foundation as an organization, that we are doing all the things for our workforce to be a great place to work. We're very focused on that, and that we have the highest levels of customer service. Keep pressing the wrong button. All right, I am going to quickly talk about a few different interoperability activities. I'm not going to go through each one of these because we just don't have enough time, but I think that there are a few to highlight because it'll tie to other things we're talking about today. Both Health Current and Coreo at the beginning of the pandemic, as we were having discussions about our potential merger, also got engaged with several of our leading HIEs across the country, including CRISP, which covers Maryland, DC, West Virginia, and several other states, Sync Health, which is Nebraska and Iowa, Indiana Health Information Exchange, which is Indiana, and Manifest MedX, which is California. We formed, and actually this is how the National Dashboard Project that Morgan mentioned came about, was through this collaboration across our HIEs, and we formed a nonprofit called the Consortium for State and Regional Interoperability. So you'll probably hear references to CSRI, new acronym for your acronym library in your mind, and you'll hear a little more from some of these leaders later today. There's this concept and transition happening nationally to progress from core kind of HIE services to this concept of health data utilities. I'm not going to talk about this too much now because I think we'll get into it more in some of the other panels today, but if you hear that term, you'll learn a little more about it throughout the day. Civitas Networks for Health, we're not the only organizations that are merging. Civitas is a merger of 2 national associations, the Strategic HIE Collaborative, which is our national HIE association, and the Network for Regional Healthcare Improvement, ENRI, came together last year and formed Civitas. So this is an entity that represents HIEs and many different types of health data organizations. You can see them listed here. So if you hear that word, you'll know what Civitas does. And they've got a lot of great examples on their website that you can read more about all the exciting things. I think it's always great to look at other examples of what we're doing and what other communities are doing that might be things we can bring back to Colorado and Arizona. I'm going to skip over information blocking, but we do have a lot of resources on it, and I'm just going to touch briefly on TEFCA. Raise your hand if you've heard of TEFCA. Okay, raise your hand if you can say what TEFCA stands for. Okay, that's about half of the people who said they've heard of TEFCA. So TEFCA is the Trusted Exchange Framework and Common Agreement. It is part of the 21st Century Cures Act, and it is a new federal initiative to further advance and nationwide interoperability. It's a contractual and operational framework for data sharing, but we have a lot of different national networks out there, so you may hear more about this. We're going to have some webinars and sessions in 2023 to make sure our community is informed. But the basics are that Contexture will have a service offering in this area. So as you start hearing more about TEFCA and you're not sure what it is, you're not sure if you should participate, how data is going to be exchanged through the TEFCA framework different than through HIE, through eHealth Exchange, we will get you more information. And there's a lot of reasons that HIEs will be a great continuous support in this area. Again, there's a lot of information out there. There's a lot of things still being sorted out. But I've run out of time today, so I don't even have enough time to talk about the basics. Did we get any basic questions that we could run through quickly? I know I'm standing between us and a break, so if there's a few, we'll take one or two.
We do have a couple. So the first one is, I access Colorado information but have patients that have moved here from Arizona. Am I able to also access the Arizona database in these cases?
So what we have a couple different mechanisms for that. We actually participate in a nationwide network of HIE exchange called Patient Centered Data Home that allows information to flow based on the zip code where you operate or where you reside, rather. The data comes back to your home HIE. I'd be happy if whoever asked that question wants to come up and talk with us afterwards. We can talk about that system, which allows for ADT alerting if you travel or move to different states. Additionally, we have, with different HIEs across the country, query of different systems. As I mentioned, we still are on 2 platforms. So absolutely, we will have that information consolidated and available in one portal in the future, but we're going to have some incremental progress in making that data available together between now and when we're on one consolidated technology system.
NARBA stands for Northern Arizona Regional Behavioral Health Authority.
Yep.
Authority, not association.
Oh, did I say association? I meant authority. Oh. Thank you to whoever made that correction. REBAs in Arizona are traditionally behavioral health authorities that support the behavioral health needs of the population, but there's been a lot of work in Arizona. NARBA is a spin-off foundation from some of that work in Northern Arizona. One more? Okay.
Part of this did cut off, but it does ask, what is Contexture doing to outreach organizations to get them to join Contexture and share information? There are a huge number of organizations that, and that's
maybe are not already connected, is what I'm going to assume. We have an entire sales and outreach team, many of whom are here. So if you're on the sales team, raise your hand. Okay, we got a few at the front, a few at the back. I know we have 1 or 2 people that are out not feeling well. So we do that work day in and day out. We have teams in Arizona, we have teams in Colorado, and we are constantly doing outreach to additional organizations. One thing that's really helpful if you're an HIE participant and there's other organizations you work with that you think would benefit both you as well as them from being connected is give us those names, because it speaks volumes for you as an organization to talk about how HIE services has helped you. Our team certainly is always more than willing to do it, but to have those referrals from you as a participating organization really helps to make that connection and can advance the conversation even further. So please provide that feedback to our team, and we will be here throughout the day. So back at 10 and have a session on the increasing value of HIE in Colorado. Thank you.